And I am so pleased to introduce to you Dr. Elizabeth Vig. She's an associate professor at the University of Washington School of Medicine, Department of Medicine, and Division of Gerontology and Geriatric Medicine. She's board certified in both geriatrics and palliative care, and her clinical work in geriatrics and palliative care is based at the Seattle VA Hospital, where she's also chair of the hospital's ethics committee. She was one of the VA's National Ethics Fellows, and her research to date has focused on how people with serious illness and their families make difficult decisions about the kinds of care they receive toward the end of their lives. And we're so pleased to have her come and talk with us today about ethical dilemmas in the care of older people with cognitive impairment. Welcome, Dr. Vig.
Thank you. And thank you everybody for coming. So I'm Lisa, and let's just get started here. All righty. Disclosure. So I don't have any financial conflicts of interests with any of this, and I'm here at the VA. So the views expressed here are mine, not necessarily the VA or anyone else for that matter. So keep that in mind. Our objectives, what I'm hoping we'll achieve in the next probably 75 minutes or so, there'll be time for questions at the end, is I'm hoping by the end of this, you all will be able to describe at least 3 ethical dilemmas that arise in the care of individuals at different stages of dementia. You will be able to describe the 4 decision-making abilities that are assessed when determining if someone has decisional capacity, and then be able to discuss the concept of moral distress and identify at least 3 of the risk factors for developing it. So how are we going to do all of this? Here's what I'm hoping to do. We'll start out by defining ethical dilemmas, discuss them a little bit, and then I've got 4 cases. And so the first case involves an advance directive with a request to stop eating and drinking. Second case has to do with guns in somebody with dementia. Third case has to do with decisional capacity. Fourth has to do with nursing home visitations or the restrictions on visitations during COVID, and that will lead us to a discussion of the moral distress that many of us are having during the pandemic. So I realize that you guys probably already know this, but just so that we're all on the same page, what is an ethical dilemma? And here's one definition. It's a situation in which there is uncertainty or a conflict in values between stakeholders about the right thing to do, right? So different people involved in a patient's care disagree about what is the right thing to do in that situation. And, you know, the disagreements, there can be lots of different disagreements, right? It could be between what the patient wants for him or herself and what the family members think is the right thing. Or it may be between different segments of the family, or between the family and the clinicians, or between different groups of clinicians. Or it can even be between what the clinicians feel is the right thing to do, but policies that may prevent them from doing what they think is right. So here are a few ethical dilemmas in dementia care. I'm sure you all could think of a bunch more. There can be a dilemma about whether to share a dementia diagnosis with somebody, and whether to promote continued driving or voting or gun owning or independent living by a person who has dementia. And then there's the struggle between whether to honor the preferences of the then self, meaning the person who didn't have dementia yet and said what they wanted in that state, or the now self. Now that I have dementia, I may have different preferences than I had before. There can be the dilemma about whether to give or withhold antibiotics or tube feedings in advanced dementia. And then the last one, whether to withhold food and drink in accordance with a directive. So that gives you a sense of some of these dilemmas that arise. And so let's talk about the issue of food and drink. And it's kind of cold and wintry in Seattle, and this picture kind of reminds me of sort of a warm summer afternoon, sun's going down. Anyway, okay, I'll come back to the lecture. So here's our first case. This is a case of Mrs. G. All except one of these cases are made up, although they may seem kind of familiar to some of you. So this is a case of Mrs. G. She's an 85-year-old woman with moderate dementia who lives in a nursing home. She wheels herself around the unit. She gets crackers from the snack cart, and she enjoys watching birds outside. She doesn't have any swallowing problems, and she enjoys ice cream, saying, "Oh boy," with each bite. She no longer recognizes her loved ones, but enjoys their frequent visits. And her son one day asks the staff when they plan to stop feeding his mother. He then produces a copy of a living will, which the nursing home staff realizes they also have the same living will in their records, which says, if I ever get to a point that I no longer recognize my family, I ask that my family and or caregivers stop offering food and fluids and let me pass. So we've got an ethical dilemma, right? And in this case, there are a couple of different potential dilemmas. So let me outline those. So one is just from the patient's perspective, right? Because prior to the dementia diagnosis, she pretty clearly documented that she didn't want to live in this state that she's now in. But now that she's here, she actually appears content and she seems to enjoy eating. So there's this tension between her then self, who wrote the directive, and her now self. Here is another potential dilemma in this case. So from the family's perspective, they feel that there's a duty to honor her preferences, right? And by allowing her to live, that's actually wrong. We shouldn't allow her to continue living. We need to honor her preferences. For the nursing home staff, on the other hand, they notice that she really enjoys eating, and they may feel that not feeding her is actually the same as killing her. And additionally, there may be regulations that in a facility make carrying out her directive very hard. So we've got these different potential dilemmas. Sometimes when we look at dilemmas, we look at ethical principles to help guide us. But in this case, I'm afraid they're not going to be too helpful. So we may look at autonomy and personhood, but if we're going to sort of honor autonomy, which self's autonomy are we going to honor? So that doesn't really help us. If we look at beneficence, doing good, and non-maleficence, not harming, which option is the good option? I think the family and the staff would disagree about that. And can staff really withhold a basic right that is giving an individual pleasure? That's going to be hard. And then we can also look at the principle of justice and start thinking about, well, do we believe that the life of someone with dementia has less value? And I think that's potentially problematic as well. So, As in many ethical dilemmas, there is no absolute right thing to do in this case. In fact, I think it's important to acknowledge that there's a conflict between two injustices. So there's not sort of one good solution for this, right? Either we violate the concept of advanced directives, or we refuse to feed someone who enjoys eating. And when you get in one of these situations where there isn't an absolute right thing, there's no easy solution, it's important, I think, to always compromise and think outside the box. And so in this case, the Ethics Committee of AMDA, the American Medical Directors Association, Society of Post-Acute and Long-Term Care Medicine, a couple of years ago now, came out with a piece about this very issue. And in their piece, and there have been other sort of ethics pieces that have sort of weighed in the same way on this same issue, they advocate for comfort feeding, meaning providing Mrs. G with foods that she likes, which also allows her to socialize with others. Because if you think logistically, if you're not going to allow anyone food, they can't really be out of their room at meal times, which is a time when there actually may be more socialization. And so sort of keeping her in her room when everyone else is eating, that sort of feels kind of icky too. You're not going to force feed her, obviously, and we're not going to worry about weight loss. She's going to eat what she wants, when she wants. But if she doesn't eat enough and she's losing weight, that's okay. And I think that's going to be important, but it's also going to be important to engage with the family in end-of-life planning. I mean, hopefully this would already have been done, but it may not have been done yet. And so what might we be thinking about? Well, we might want to discuss what the overall goals of care are. We definitely would want to talk about code status if that hadn't been addressed yet. We'd also want to talk about antibiotics, right? Because as dementia progresses, people often will develop different infections. And, are we going to treat those palliatively with medicines to make the person feel better? Or are we going to give antibiotics to treat that infection? That's an important discussion. And we also may want to think about the issue of hospitalization. If she develops a problem, would we ever consider hospitalizing her, or would the family prefer to keep her at the nursing home? During this planning, I think it's often important to also talk about prognosis. And I just make you aware of the ePrognosis website. I think you can just Google ePrognosis, or you can go to eprognosis.ucsf.edu. And when you get to that site, it takes you through, it asks a bunch of different questions, like is the person in a nursing home or not, et cetera? Do they have dementia, et cetera? And it gives you, at the end of answering all these questions, an estimate of the person's prognosis. And I think in this case, it might be important to do, because I suspect the family's thoughts about her prognosis may be different. That is, the family may think she is closer to the end of life than she really is. I went to this site and sort of made up some stuff to put in, and she could live for months to even years. And the family may not realize that. So one way to kind of make this official would be to fill out a form like a POLST form. So in Washington State, we have the POLST, which stands for Physician Orders for Life-Sustaining Treatment. And these are physician orders that are valid in like a nursing home or outpatient environment. At least here at the VA, the POLST orders sort of inform what we do in the hospital, but when someone gets hospitalized, we have our own set of orders. Anyway, and I can't remember how many states now have something like the POLST. Not every state does yet, but you can actually go to, I think polst.org will tell you which states have what. So there are 4 sections in our Washington POLST form. The first is about code status. Does the person want to have CPR or not? The second section is about sort of your overall focus or goals of care. Do you want full treatment, meaning you're okay being in the ICU, you're okay being on a breathing machine or having dialysis, etc. Or maybe you don't quite want that, but you're okay what we call selective treatment, meaning maybe I have a pneumonia and I'd be okay going to the hospital and having that reversible pneumonia treated with IV antibiotics for a little bit. Or would I prefer comfort-focused treatment, meaning, you know, everything will be done to make me as comfortable as possible, but I really don't want to go to the hospital at all, if possible. Next part of this is about antibiotics, whether to use them to prolong life or basically not to use them. And then the last section is about feeding tubes. So if we go through and complete a POLST form with Mrs. G's family, what they might want, based on the beginning of this case, I suspect, would be that she would have a do not resuscitate order, that she would have comfort-focused care, that she would not have antibiotics, and that she would not have feeding tubes. And nursing homes will sometimes also have a do not hospitalize order, which in her case might be something to also think about. So there. In the world of ethics, you know, every case is a little different. And I put some different things we might consider in this case that might make us weigh in a little differently. So, you know, what if Mrs. G was at home and she wasn't in a nursing home? Then, you know, the family could probably stop feeding her and giving her water. If someone questioned it, though, that's a little legally problematic. At least in our country, there haven't been cases or enough cases about this for there to be like a real legal precedent. So I think it's a little problematic in somebody who's not terminally ill. And what if, you know, because the nursing home staff didn't feel comfortable stopping feeding her and giving her fluids, what if the family said, well, we're going to take her home and do this? So that would probably make the staff really uncomfortable. And just so that you're aware, there was a case like this in Canada, the case of Margot Bentley, which you, I think, can Google and learn about. It's a really sad case. So she was a nurse who had completed a directive prior to developing dementia, you know, saying exactly this, was in a facility, developed dementia, family asked the facility to stop feeding her. They said they wouldn't do that. Family then said they would take her home and do this. The facility called the police. This went to court. And it's sort of awful because, you know, the family, I think at some point couldn't even come and visit her in the nursing home. So just something to be aware of. We might also weigh in a little differently if she didn't seem so content and she didn't seem to be enjoying eating so much. And I think if she was aspirating, we could do comfort feeding, probably changing the consistency of the foods and hopefully finding things that she would like the ice cream. She could probably still have ice cream. And if she was clenching her teeth when staff tried to feed her, then that's not comfort feeding, right? And so then we would probably say, yeah, it's very appropriate at this point not to feed her. And so a resolution on this case. So the staff and the family met, they completed the POLST. The family was a little distressed to hear about her prognosis being longer than they expected. And at that point, social work can offer support, can direct the family to resources from the Alzheimer's Association, etc. So take-home points from this case. I think many of us believe that if we've completed a directive, everyone has to honor that. I would say that there are limits to what we can actually honor that's written in a directive. It's important to recognize both the family's distress and the staff's distress around this issue. And when there aren't any good, easy solutions, compromising and thinking outside the box is always going to be the best option. We're going to see that again. So that's our first case. I'm going to keep going. Let's go to our second case. So this is a case of Mr. H, and this is a real case. So it was I took this from USA Today back in 2018. This is a case of Mr. H. And this picture here is of Mrs. H. So Mr. H, 76-year-old former police chief and county sheriff. He had a dementia diagnosis for about 2 years before he accidentally shot his wife of 57 years. She apparently had taken away his car, but not his gun. And here's a quote from what she said. She said, he was just almost obsessive about seeing his guns. He spent darn near 40, almost 50 years in law enforcement, and a gun was always with him. And so to deprive him of not even seeing them, in my heart of hearts, I couldn't deny him. Whew. So a few statistics for you. It's estimated that about 45% of people with dementia either own a gun or live in a household with a gun. That's a lot, right? By 2050, it's estimated that 13.8 million Americans will be living with Alzheimer's disease. And as a geriatrician, I have to point out that as dementia progresses, people may be more prone to impulsivity, paranoia, and delusions. So this is a setup for bad things happening, like what happened to Mrs. H, right? And so what are the potential ethical dilemmas here? Well, there are a bunch of them, just to warn you. So one, the individual with dementia, like Mr. H, may want access to their guns. And unlike Mrs. H, the family may be uncomfortable with this. Or the patient and family may think the patient should have access to his guns, but the clinicians may be uncomfortable with this because they want to promote the health and safety of patients, families, and the public. And then just with the clinicians, there's also a dilemma, right? So yes, they want to promote health and safety of patients, families, and public, but they also want to protect their patients' privacy and maintain trust, right? And at least in the issue of driving, clinicians are often kind of torn with whether to call the DMV and rat on their patients or not. And so, again, thinking of the ethical principles, there is sort of this tension here about honoring patient autonomy versus protecting the public. And as I said, the ethics of it is very similar dilemma to driving. And so in this one, there's not an easy fix either. And so again, I would urge, people to think about compromising and thinking outside the box and what might be some options. So I found this really helpful paper that came out a couple years ago on this very issue, and they have a bunch of suggestions for things that can be done. So they suggest having a discussion, sort of an advanced care planning discussion around firearms. So if someone doesn't have dementia, but we know they have guns, it may be a good idea to talk about all this before they develop dementia, so that there's sort of a plan in place for what will be done. Sometimes, people talk about a driving retirement date. Here, they talk about a firearm retirement date, which everyone can agree on. So that's another option. Families should be encouraged to lock up guns and reduce the lethality of them by, storing them unloaded, using blanks, disabling the trigger mechanism, and if possible, removing guns from the home. But I guess this, I've learned some stuff here, because I didn't realize legally that's a little tricky, right? So if the gun is registered to the person with dementia, taking that gun out of that house and putting it in someone else's house could be legally problematic. And apparently, some gun shops, shooting ranges, and law enforcement will store guns for people. So that's one, some options. I also learned about these red flag laws, which are also called extreme risk protection orders. It seems like more and more states are getting these. They're now valid in 19 states and the District of Columbia. In the Northwest area, Washington and Oregon both have these laws. And basically what they are is that family, friends, or law enforcement can petition the courts to confiscate somebody's firearms because of a concern that they're at risk. The judge then determines if that individual is a danger to themselves or others. And once one of these orders has come out, it will last for 6 to 12 months. So that's just something to consider. And I suspect clinicians could also petition the courts, although then there's again the issue of ratting on your patients and sort of having to weigh, the risk to society or others versus what that patient is going to think about trusting you in the future. The Alzheimer's Association has some resources on this, so I just put this here to remind myself to mention that. You can sort of Google Alzheimer's Association and then firearms or guns. And because I mentioned the issue of drivers, I also put this up because the American Geriatric Society has come out with a revised version of this guide, this clinician's guide to assessing and counseling older drivers. It's very good. It's very long, but there are lots of good sections that can be really helpful. And you can just Google this and get the whole document online. So just so you're aware. So case resolution on this one. So Mrs. H actually underwent multiple surgeries. She survived, thankfully. And after all this, she didn't even regret showing Mr. H the gun. So there you go. So take home points from this one. I think it's always important to ask about gun ownership, probably sooner rather than later. Discuss options to promote safety, develop a plan. And in situations like this, I think it's really important to document the discussions that you've had so that there's evidence that you did bring it up, you informed people of the risks, et cetera, just in case something bad happens in the future. Not that we want it to, but there's that risk. So that's case number 2. Let's move on to case number 3. This is a case of Mr. S. He is a 78-year-old man with mild to moderate dementia who was newly diagnosed with metastatic prostate cancer. His wife brings him to your clinic to discuss treatment options, which include surgery, chemotherapy, radiation, and immunotherapy. It may be that they had a meeting with the oncologist and it just didn't seem like Mr. S was, making a decision, and Mrs. S may sort of defer to him. And so now they come to you in hopes that you, the primary care provider, can help. And you start wondering if Mr. S really has the ability to make this decision. Does he have decisional capacity? And decisional capacity is the capacity to make one's own decisions and is fundamental to the ethical principle of respect for autonomy and is a key component of informed consent to medical treatment. So let me talk a little bit about decisional capacity. So patients need capacity to do a bunch of different things. They needed to accept and refuse medical treatment, to return to independent living, to leave the hospital against medical advice, to participate in research, to complete an advance directive. And if you live in a state where death with dignity is legal, you need capacity to make a request for the medications that you would use to end your life. So capacity is linked to informed consent, as I just said. I'm sharing here part of our VA informed consent policy, just to give you a sense of what's in there. So it says, informed consent process for patients who have decision-making capacity. The informed consent process involves the following procedures. So, 1, provide information that a patient in similar circumstances would reasonably want to know. 2, describe the recommended treatment and procedure in language that the patient can understand. 3, describe expected benefits and risks. And 4, describe reasonable alternatives, right? So you discuss the risks, the benefits, and the alternatives. A little more about capacity. Capacity is presumed unless there is evidence to the contrary. And just because someone is refusing something doesn't mean that they don't have capacity, right? They may be thinking about all this a little differently than we are. Capacity is decision specific. So, global incapacity, where you can't make any decisions is less common, right? If I'm in a coma, yes, I have global incapacity. But if I have dementia, I may be able to make some decisions, but not others. The other thing to remember is incapacity isn't always permanent, right? So if I develop delirium and I'm really out of it, yeah, I won't have capacity when I'm really out of it, but when I clear, I will have capacity again, probably. Last point, any clinician can determine capacity in routine cases, right? We don't need our mental health experts to come in and do this for us every time we're wondering. yes, we want their help with the really hard, kind of extreme cases. As I said, people with dementia and other cognitive disorders aren't automatically incapacitated. And at least our Washington state law reflects that, right? Age, eccentricity, poverty, or medical diagnosis alone shall not be sufficient to justify a finding of incapacity. I like how they worded that. A little about the prevalence of incapacity. So this is an older study, 10 years now, wow. I don't think things have changed too much, but anyway. So here's the prevalence. In healthy older people out in the community, maybe 3% can't make their own decisions. Those with mild cognitive impairment, about 20%. Parkinson's disease, 42%. Those in nursing homes, 44%. And those with Alzheimer's, about half. So that means about half of the people with Alzheimer's can make some decisions. The other point that they noted in this study was that we only recognized the incapacity about 42% of the time. So keep that in mind. So how are we going to determine if someone is able to make their own decisions or not? So there are 4 decision-making abilities that we assess. So understanding, appreciating, reasoning, and choosing. And what are those? So understanding means if I shared the risks and benefits and alternatives with someone, do they take all that information in and can they repeat it back to me in their own words? Appreciating is the ability to understand that all this stuff that you're talking about actually is going to be affecting your own body, right? So if I'm in denial, I may have a good understanding and be able to rattle off all that information I was just told, but then I would say, but none of that applies to me because I don't have that problem. Okay. Reasoning is the ability to take all that information in and then understand sort of the consequences of different decisions or weigh those different decisions against my core values and make decisions that are similar to other decisions that I've made in my life. And then choosing is the ability to choose something and make similar decisions sort of over time. So let me give you an example of this. So in the case of Mr. S, we would first start out by getting a sense of his overall cognitive status. So, nothing to do with treating his prostate cancer at this point, but just sort of what's been going on. Can he tell you sort of things that have happened to him recently in his life? Or why did your wife bring you in today? Does he have a sense of why they're there, what they want to talk about? The next thing to think about is, does he want to make his own decisions? So people who have decision-making capacity may really not want to make those decisions, right? They may want to defer to someone else, and they have every right to do that. This just gets into that a little. Next, we would want to assess his understanding of his diagnosis and the treatment options. So yes, he's been told all this before, but I think it's always good to sort of rehash everything to make sure someone really has been told it. So what have your doctors told you about your prostate cancer? What have they said about the different ways it could be treated? And as I mentioned before, we would then hope that he could repeat this information back in his own words, right? We would be looking to see if he was aware that he has prostate cancer that's moved to his bones and that there are different treatment options each with different pros and cons. Appreciation, we would want to sort of have a sense that he understands that what we're talking about has to do with his body. And then the reasoning, we would want to make sure that, his choice is consistent with his values and his past decisions. Why is that the best choice for you? And maybe I should switch these, because you'd want him to have the choice and then ask for the why, right? What's the best choice for you and why, to see if that sort of fits. Here's another approach. This comes from Dr. Siegler at the University of Chicago, and he's got 5 questions that he asks. What's your main medical problem right now? What treatment has been recommended? If you receive this treatment, what will happen? If you don't receive this treatment, what will happen? And why have you decided to or not to receive this treatment? So that's pretty straightforward. I like this one. And then just so that you're aware, there's this instrument, the Aid to Capacity Evaluation, which I think you can Google. And it has something like 8 questions that can be asked. So that sort of get at these different issues. So is the patient able to understand their medical problem? Do they understand the proposed treatment? Do they understand the alternatives? Do they understand that they have the option of refusing? And do they understand the consequences of accepting and refusing treatment? So, case resolution. So Mr. S actually doesn't remember that he has prostate cancer, and he states that he couldn't have this because he isn't uncomfortable. So basically, he doesn't have the capacity to make this decision. So in that case, what are the next steps, right? He can't give informed consent, but that doesn't mean he can't still express values. He may be able to say that he doesn't want to go to the hospital and, be hooked up to an IV, or he really wants to be comfortable and he doesn't want pain, or he doesn't want nausea. Those kinds of things may be helpful in informing a decision. And yes, he can't consent, but we want to honor his personhood, and he still needs to assent, meaning he still needs to agree with whatever his legal decision maker consents to. And I think we just had a case kind of similar to this in the hospital last week, where the legal surrogate may say, go ahead, do this, but logistically, it may be very difficult if the patient isn't in agreement, right? If Mr. S, really was scared of radiation, and Mrs. S said, no, he should have radiation. Logistically, how are you going to have him go in every day, lie down, be really still, etc.? That's not going to be possible. So, obviously when someone doesn't have capacity, we're going to involve their legal decision maker. And I know I always go over this, but I'm just going to include it because it's important to remember. And there've been some changes. How we identify someone's legal surrogate decision maker. So every state and the VA have a law or policy around this. And the way to find the person is you start at the top of the list and you go down until there is one or more people in the category, right? And so because I'm at the VA, I use the VA one. If any of our VA patients go to another hospital outside the VA in Washington State, the Washington State one counts. And I used to say that the VA one was really good because it went all the way down to close friend. But Washington actually changed their law a little bit in 2019. I think it was 2019. And now it goes all the way down to what they call an involved other, which I think is great. But you may not be calling in from a VA or Washington. And so I put this here because the American Bar Association's elder law section has a document that they update probably every couple of years that has every state's law. I put a link to it here. I think if you Google ABA, default surrogate consent statutes, you can get to it, although I'm not totally sure. So hopefully you can get to it through this link. That one I know is valid because I just tried it. And so the take-home points from this is that patients with dementia may retain capacity for some or all decisions, and capacity is determined by assessing the 4 decision-making abilities. Those without capacity can still express their values and need to assent to treatment. So that's the 3rd case. All right, let's move on to the 4th one. Whew. So this is a case of Mrs. K. She is an 80-year-old woman with a history of breast cancer. She lives alone. She comes to see you in clinic complaining of insomnia, weight loss, and difficulty concentrating. Further questioning reveals that her husband of 50 years lives in a nursing home due to dementia, and she hasn't been allowed to visit him for 10 months. And this is a picture from the internet. It's, not the real person. It's a nice picture from it's kind of a sad picture from the internet. And so this is something we've heard a lot about, right, in the last year or so. And so one possible response to this, and people have very strong emotional responses to this, this is wrong, right? Mrs. K needs to be able to visit Mr. K for both of their sakes. Keeping him isolated is worsening both of their quality of life, right? And I would say that, yes, this is a very valid response to this awful situation, but unfortunately, there are other things we need to consider. And this is where we have a tension between clinical ethics and public health ethics. And I think most of us are very used to working in the clinical ethics realm, right? Where we focus on the individual patient, where we provide patient-centered care, where we elicit the patient's values, right? However, during a pandemic, we kind of shift away from that to more of a public health ethics focus. When we can, we're going to continue to focus on the individual patient, but overall, we take a broader view of things, right? We focused on the community. We try to maximize the greater good. We try to allocate things fairly. And it can be really, really hard to shift from one focus that we're used to this other focus. Let me go a little bit more into this. So option 1, if we allow visitors, that's taking sort of a clinical ethics approach. We're going to focus on the individual patient. And our aim is going to be to promote psychological or emotional health, cognitive stimulation of the person in the nursing home, and socialization with loved ones. Option 2, the no visitor option, is a public health ethics approach. There's going to be focus on the entire health of the community, and our aim is going to be to promote physical health and life. So what are the consequences? So the consequences of option 1 is there is going to be increased illness and possibly death of other nursing home residents, of staff, and of family members, of staff or residents, I guess. And there's going to be the possibility for decreased staff availability due to illness. We know sort of early in the pandemic from places like New York that, nursing home staff, because they aren't paid very well, often work at multiple facilities and actually were working even when they were sick. The no visitor option consequences are, yes, we're going to have worse psychological and emotional health of our residents, of our staff, and of our family members, like we saw in the case. And there also is the option that at least those with dementia are going to have more cognitive decline. So this is sort of awful, right? Again, there is tension between ethical principles, between beneficence, doing good, and non-maleficence. But again, what's the good thing to do? It sort of depends, right? And if we look at justice, this gets really tricky too, because if we let family visit one patient, is that fair to everyone else? And if everyone is allowed to visit, how does that impact everybody else's risk, right? The staff's risk, the other residents' risks, and all the family members' risks. This is sort of awful, right? It really is. Here are a few statistics that I found on the CDC's website. So nursing home residents are an extremely vulnerable population with the highest death rates. And there was something that just came out this weekend that I saw about people with dementia having even a higher risk of getting COVID. But this is all older people, not just folks with dementia. So compared to 18 to 29-year-olds, you can see the increasingly high rates of hospitalization and, super high rate death rates, right? So for those 85 years and older, they have 630 times the death rate. I mean, I'm not used to seeing things that are that high. Holy moly. So that's huge. The other thing to remember, and I know you know this, but everyone in a nursing home is connected, right? The patients, maybe the nursing home is trying to keep the patients from interacting with each other or the residents, but the staff is still going, from one room to the next room. So there's really no way to keep everyone from being connected like this. And so what can we do in this awful situation? Again, we're going to need to think about compromises and thinking outside the box. And so some suboptimal solutions that I recognize are suboptimal, allowing visitation in special circumstances. So in our nursing home here at the VA, and things really have changed a bit at different times during the pandemic, when someone is actively dying, they can have visitations. Or in some situations, we allow very limited visitation, meaning one person can visit for 1 hour once a week. That's going to increase everybody's risk a little bit, but we're again weighing these two awful options. Video visits can be used, but again, for some people with dementia, that's not going to work. And then outside distanced visits may work, but it's like 20 degrees in Houston, right? So that's not going to work. So I acknowledge this is awful, right? And this is how all of this may make us feel. And so I use this to sort of transition into talking a little about moral distress, because that awful feeling that we have around this case, I would argue, is moral distress. So I'm going to talk a little bit, I got to speed up, what it is, who gets it, clinical situations that can lead to it, some other risk factors, some COVID specific risk factors, why moral distress is such a big deal, and what we can do about it. So what's moral distress? Well, it occurs when you believe you know the right or ethically correct thing to do, but something or someone restricts your ability to take the right course of action. And you're actually forced to act in a manner that goes against your core values. So basically, you are doing something that you feel is wrong, like big capital letters, wrong. If you look in the literature about who gets moral distress, it's basically everyone. We'll just say that, everybody. So what are some of the clinical situations that can lead to moral distress? Oh, and in your handouts, I sent a handout that on one side has a whole bunch of different risk factors for moral distress, and on the other side has this moral distress map, which we'll talk about, that groups can use to kind of go through a discussion about a difficult case. So some clinical situations, when there are unclear goals of care, when we feel like we are not honoring a patient's preferences, when we continue life support in situations we think are futile, when we believe that false hope is being given to patients and families, when what we're doing is hastening death, when we're not able to get a patient comfortable, or when there's inadequate staffing on a unit or inadequate training of staff, and when there is thought to be inappropriate use of scarce resources. And then some other risk factors for moral distress. So there are individual and organizational risks. So some individual risks, when we have a sense of powerlessness in a situation, or we don't feel like we really understand the whole situation. We can't really identify all the medical issues, when we have self-doubt, or when there's a lack of assertiveness. We don't feel comfortable stepping forward and asking questions about why. Why is this happening? On the organizational side, when there are power imbalances between disciplines, or poor communication between disciplines, or a lot of pressure to decrease costs, poor staffing ratios, or a lot of turnover on a unit, or fear of litigation, or lack of administrative support, or certain policies may also contribute. And I put this slide here to remind myself, periodically we will do debriefs with work groups who are all having moral distress about a situation. And when we discuss it and we go around the room, different people in the room may be getting moral distress about different aspects of the case. So yes, we all have moral distress, but it may not all be about the same thing because we're all different, right? And then thinking about some COVID specific risk factors for moral distress. And thinking about this, there are a whole bunch of them. So no wonder we all have moral distress, right? So I tried to organize them. And so some patient factors, it may be that we are so overwhelmed that we are providing or feel like we're providing suboptimal care to people just because of the sheer volume of patients. Or it may be that we aren't feeling like we're providing adequate symptom relief, right? Because of scarcity of meds or scarcity of oxygen. Or we may feel that we aren't honoring patients' preferences. So if we get to crisis standards of care where we really don't have enough resources, then groups are going to be triaging who gets the ventilator and who doesn't, right? And so that may cause moral distress. Some may feel that resuscitating patients with COVID is wrong. And some may feel that providing care to COVID deniers who've been out doing whatever is wrong. And then some clinician factors. So especially early in the pandemic, there was a lot of distress around working, putting both oneself and one's loved ones at risk. And people were reassigned, right? So some of our nurses, I think from primary care, were reassigned to our ICUs. And so they may not feel like they have the knowledge and skills to do that. And some people are super busy and overwhelmed, while other people may not be as busy and feel like they really need to get in there and help, but they can't. And so they may actually have moral distress due to bystander guilt. And then some institutional factors. So there may be inadequate staffing due to illness of staff or redeployment. There may be inadequate PPE, which is giving people moral distress about what to do. Earlier in the pandemic, there was pressure at times to use untested medications, that someone might feel like giving that medication to someone when it hasn't really been tested is wrong. And I think because all of us are more stressed out, right? Some people, when they're stressed out, will have more disruptive behavior. Here at our VA, we've run into the issue of staff feeling like they are supposed to stand there and take it when a patient or family member are yelling at them. And that can cause moral distress. And no, they don't have to stand there and take it, but we're working on that. And then at times there has been a sense of frontline staff receiving inadequate information and from leadership not being transparent. And then some policy issues. Throughout this, there has been lack of control for all of us due to government mandates, right? I work full time, all of a sudden I need to homeschool my kids at the same time. So that can cause a dilemma. The rules have changed a lot. If I'm a rule follower and the rules change every day, I'm going to go nuts, right? Those involved in triaging who gets the scarce resources may be at high risk for moral distress. And then, as we just talked about, enforcing the no visitor policies. So, I'm totally biased about this, but this is why I think this is such a big deal. And I think after this is all over, there's going to be a high impact on all of us having gone through this. And so there's this concept of this crescendo effect. So if we start way over on the left, the first time we ever have moral distress, our moral distress crescendos up, right? But then the case doesn't last forever and it resolves somehow. And our moral distress comes back down. But you'll notice that it doesn't come back down to zero. We sort of are at a new baseline. So each time we encounter one of these things, we end up with more of what they call this moral residue, sort of this feeling that kind of hangs out with us. And that's a problem. And why is that a problem? Well, this quote, I think, starts to get at that. This comes from a NICU nurse who said, like I said, the floggings, the situations where our ethics have not kept up with our technology, the fact that we can keep someone alive knowing full well that their outcomes are poor will make me stop in this field, right? So this person recognizes at some point they're going to get to a point where they just can't do it anymore. And this gets at some of the consequences of untreated moral distress. So if, again, you start over on the left and you go across the top row, what's the impact on the patient if those taking care of them have moral distress? Well, we're not going to be able to advocate as much for that patient, and we may avoid going in that room altogether. So that's going to impact that patient, right? They may have more discomfort and suffering. If we go across the middle row, what's the impact on, it says nurse there, you can put whatever discipline you'd like in instead. That clinician or healthcare provider is going to be suffering. And as we just heard from that quote, eventually that person may get to a point where they just can't do it anymore. And they may quit their job, they may burn out, or they may leave their profession altogether, which I think is really tragic. And then what's the impact on the organization? Well, there may be a lot of turnover, and it may be difficult for that organization to recruit people to replace them. And there may be decreased quality of care and low patient satisfaction, which can affect reputation and accreditation. And I think this is why organizations need to pay more attention to this. So what can we do about it? You know, I wish we had sort of a magic wand or a fairy godmother who could, you know, poof, make it all better. But until then, here are some things to think about, right? About what we can do. So sort of a forest and trees issue, right? There are different interventions. There are individual interventions, team interventions, and organizational interventions. But I think we need a little of all of them. So example, if you work on a floor where there continually are these cases that trigger moral distress, and nothing is done to change the root causes of those triggers, then you as an individual can do like all the mindfulness in the world, but it's still going to be really hard to get out of bed in the morning, right? So you need some of all of these. So let me go through some examples. So individual interventions. So the American Association of Critical Care Nurses has a moral distress site with lots of good information, and they give some good examples. Here are a couple of quick ones. One, starting shifts with a moment of gratitude. And there's a fair amount of literature about the benefits of gratitude. And then also having rituals in place to honor the life of patients who've died. The National Academy of Medicine has some COVID-specific well-being resources. The American Psychological Association has a lot of good information on counteracting burnout. I know there are a bunch of other ones out there, but just some suggestions. And then finding ways to cultivate moral resilience. This paper came out a few years ago, and it is just awesome. And talks about different ways to cultivate moral resilience. And let me go through these quickly. So one is mindfulness. And I agree, some people roll their eyes. I used to roll my eyes when I heard about mindfulness because it was like everywhere. It's like kale, right? It's good for you. But if you really learn to do mindfulness, part of it is learning to be okay with things around you not being okay. And I would argue if you're dealing with moral distress, things around you are not okay. Then developing self-awareness and insight. What are the things that get you all riled up, right? And the next one is kind of connected, because if we recognize what gets us riled up, maybe we can disrupt things before we start spiraling into negative patterns of thinking, right? Oh, we had a case like this last year and it was such a disaster and it was so awful, yada, 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 right? If you identify that, maybe you can stop it. Moral sensitivity, being able to put yourself in the other side's shoes and try to see where they're coming at it from, right? Most of the time they're not evil, they're just seeing things a little differently. Discerning the ethical challenges. What are the sort of conflicts in ethical principles that are leading to this dilemma? Taking courageous action, being able to step forward and ask those hard questions. And then finding meaning in the midst of adversity. So maybe there's an awful case, but something good comes out of it. We had an awful case years ago in our ICU, and as a result of that and the moral distress everybody had, our chaplains now do a monthly check-in with everyone to provide support, which has really been helpful. And then finding ways to preserve both self and team integrity. This is one team intervention. It's called the unit-based ethics conversation. We do it at our VA, It's a facilitated discussion with a group who is struggling with a difficult case. You can do it during or after this case. The goal is not to fix the situation, but to provide time and space for everyone to discuss their perspective. And it's really important the whole story out, because often different people will have different nuggets. With when the whole story is out and when all the nuggets are on the table, people may realize that they had been misinterpreting the situation. And then because we're running out of time, I'm not going to give you the story I usually tell with that. And then at the end of this session, we point out the ethical principles, concepts, and dilemmas. So that's one team intervention. Another team intervention, which is on the other side of your handout, is the moral distress map, which comes from Denise Dudzinski, who's here at the University of Washington. And it's basically a framework for having a discussion as a group. So for first, people identify the emotions that they're experiencing about this case. Then people try to identify what for them is the source of their moral distress. They figure out what the internal and external constraints are to taking the action they feel is right. They think about the different values that are in conflict. Think about the different actions they could take, the different options out there, and then what action they should take going forward. And then I end with this, saying that you can do individual and team interventions, but it's also important for the organization as a whole to support this. And so for that to happen, first we need to identify the risk factors within our organization that are causing moral distress. And we need our leadership to actually acknowledge this, right? And then we need leadership support for interventions that are going to be aimed at reducing these risks and interventions to support our staff going forward before everybody quits or burns out, right? So that's what I was going to say. So if people have questions, I can't see the chat. I guess I could close this out a bit.
I've got it, Lisa.
You got it? Oh, yay. Thank you.
The first question was a while back, but it asks about that ice cream example, the patient returning home with family and family withholds food.
Mm-hmm.
Has that been an issue with police that investigate after death? Does the patient need to be in a hospice program for this not to be a quote unquote neglect situation?
Yeah, and so I don't totally know. This is a new enough entity that there haven't been enough court cases around this. There's the one from Canada, which, had the awful ending. And I sort of bring that up as sort of a cautionary tale about people going this route.
And Lorraine mentions that Wyoming has the same POLST form that we do. Are there any restrictions on what a person can put in an advance directive? I'm just wondering if there could have been an intervention at an earlier point to head off that. I'm not exactly sure which ethical dilemma, but.
Yeah, so I think there's a lot of belief out there that when you put something in an advance directive, it's going to be followed. And I would say you can put whatever you want in there. We actually had, okay, maybe this is inappropriate, but we had one guy here at the VA who had in his advance directive that after he died, he wanted his testicles removed and dropped over someplace. I mean, some really wacko thing. So yeah, you can have whatever you want in there. Whether it's going to be followed isn't necessarily true. We have cases where the legal surrogate makes decisions that are different than the advance directive and may have really good reasons for that.
Catherine Contway, who's a certified clinical trauma professional and a social worker, said that she sat on a bioethics committee while working for APS and working with the legal guardianship office. And she just mentions that she was confronted with many ethical issues involving clinical versus public health.
So even when there wasn't the pandemic, yeah.
Are there CDC stats for COVID risk in older persons' recent numbers or from earlier in the pandemic? Mary, if you can say a little bit more about that question. Are the CDC stats that you were giving for COVID risk in older persons, are they recent or were they?
I found them last week.
Okay, great. That's it. I read that wrong, sorry.
Yes, I was doing my slides last week. I'm not super organized here. Yeah.
And someone from the VA just mentioned that this was excellent timing of the talk where you're describing the CLC at American Lake, and it will be useful in explaining this situation to staff.
Well, good. I'm glad.
Can you briefly talk about sexual consent in people with dementia?
Oh, that's a whole nother talk. I was gonna do a case like that, but there's all this literature. I got it right here on my desk that I haven't read through yet. So there's some good articles that have suggestions of what to do. I'm gonna have to tackle that one next time though. I'm sorry to do it justice because it comes up all the time.
So how do you disable a trigger, and wouldn't that make a gun owner angry? Back to your
yeah, especially this case of Mr. H.
Yeah.
You know, I'm sure because, you know, what do they call it? Our motor memory, you know, even though his cognitive abilities weren't great, I suspect he still would have figured all of this out. Yeah. So it's all, yeah, it depends on the person, I think, which of the options might be reasonable.
And Erica mentions that about guns, that really 40% or more of people with dementia live in a home with a gun. She was surprised to see that.
Yeah, it's scary, huh?
And Kevin mentions removing the firing pin on the gun. I don't know much about guns, but
yeah, I don't either.
That's helpful. Any other questions, folks? Do the 4 M's come into play when there is doubt or confusion regarding something like the ice cream lady example? In other words,
well, so the sort of what matters most is, I think, the biggest one, and the issue becomes again back to the sort of issue of then self, now self. So what mattered most to me before I got dementia may be very different from what matters most to me now that I have dementia.
And how do you navigate that?
Right. So as I said, there's not an easy answer. So it's sort of the sitting down with the family and compromising. And, you know, at least in that particular case, there is now at least 3 published things that all talk about the importance of comfort feeding in those situations. Mm-hmm. Meaning giving the person what they want when they want, but not worrying if they're not eating a whole lot.
Cynthia wonders, do you think the issue of moral injury should be broached with staff before they bring it up? I think we should be proactive about that, or they may feel they have to be brave and carry on.
Mm-hmm. Yeah, and I think at least, you know, in the physician world, at least when I'm old, but when I went to med school, we were taught that you're sort of supposed to be tough and just keep soldiering on. And I remember even back then, I thought that was just wrong. And so I think giving people permission that, especially with the pandemic and all our chronic stress, that it's okay to feel awful. And the other thing about moral injury and moral distress is people who have it may not recognize it. So if you're able to recognize it and point it out in others, I think that's important to do.
Dan mentions, back to the gun issue, something that may be relevant, particularly for the veterans. Have they ever discussed the disarmed or panicked feeling they get when their weapon is not with them. It was a very big adjustment during redeployment, apparently.
Yeah, and I think, this case of Mr. H, I think his wife felt that he would just get more anxious and agitated if he couldn't ever see his gun. So I think you're very right, Dan.
And Carrie says she loves the book Being Mortal. It suggests a series of discussions with our medical power of attorney so that this person can make an informed decision rather than using specific Q&A forms.
It's a great book.
Seems like several other people echoed that. I don't see any other questions. So I just really want to thank you. You brought up some great considerations about some very kind of challenging dilemmas, and we really appreciate it. And we will see you next week, everyone.
All right. Thanks, everybody. Be well.